terms of the background, we have excellent data in diabetes, particularly type 2 diabetes. We've got randomized controlled trial evidence of what we need to do. And on the basis of that, we have a number of international guidelines. This is the ADA, ESDA position statement. But the key in all the guidelines is that we need to manage the risk factors. So this is from the ADA standards of care. I was fortunate enough to be on that. We've made it very simple. If we need to look after people with diabetes, we need to control their glycemic control, blood pressure management, lipid management, and agents that protect cardiovascular disease and kidney disease as well. It's as simple as that. It's important also to prevent the microvascular complications. What we've done is, over the last few years, since the EMPEROR trial came out, we've concentrated very much on the cardiovascular outcomes using these excellent therapies, but we've lost the touch with microvascular complications. Microvascular complications, as you can see from this study, from a friend of mine, Kashif Ray, who presented here a few years back, they are also associated with cardiovascular disease and mortality. This is presence of 1, 2, or 3 microvascular complications and their associations with cardiovascular events in people with type 2 diabetes. What you see here is the microvascular risk complications are much, much greater than the risk for cholesterol, for BMI, blood pressure, and HbA1c. So if we can prevent very early on the microvascular complications occurring, then hopefully we will prevent cardiovascular outcomes later on as well. This is data we looked during COVID. We know over the 2 years of COVID, people didn't get their risk factors controlled. Because of the pandemic, we didn't see these people face to face particularly. What we showed here is that 8 care processes. These are simple things that we do in clinical practice, checking their blood pressure, checking their HbA1c, checking their weight, checking their eyes, checking their urine. If they are done to the right level of standard, they have much, much benefit. So the reference here is having all 8 risk factors or process measures controlled. And what we see is if you only had 5 of those controlled in the previous 12 months, or 6 to 8, 7 control, you had a much increased risk of mortality. And this is for men, women, by age, and ethnicity group. So seeing these patients doing the simple things right is very, very important. And this is data to show how much bang we get for our bucks in terms of reducing risk factors. So if you look at this in terms of 0.9% reduction in HbA1c, we need to treat 119 people to prevent 1 cardiovascular event. But what we achieve by reducing cholesterol or reduction in blood pressure is much, much greater. Not that we shouldn't look after HbA1c, because that's the one that's more associated with microvascular complications. So we have great evidence from randomized controlled trials about risk factor control. Does this translate into clinical practice? Unfortunately not. This is a systematic review of 24 studies, over 300,000 patients, showing that globally, we only achieve HbA1c target for about 42% of our patients, blood pressure targets for only 29% of our patients, and LDL cholesterol target for only about half of our patients. So despite the high quality evidence, and these are simple things to do for our patients, we're still not achieving these targets. The key thing is making sure that we manage the risk factors early. Roy's talked about reversal, but if we are not able to reverse the risk factors or diabetes, even in those who reverse, I think we should still aim to get early risk factor control. And UKPD has showed this to us, that early type glycemic control. As you can see, this is the conventional arm versus the metformin arm. At the end of the trial, there were microvascular benefits. 10-year follow-up, there were macrovascular benefits with the microvascular benefits sustained. And now we have 40-year of data, again confirming the benefits of tight glycemic control. And UKPD has termed this the legacy benefits of controlling tight glycemic control. This is one of Ralph DeForzo's study, again showing early tight glycemic control. So this is a really neat study where they looked at patients who were newly diagnosed, put them onto triple therapy from diagnosis, and compare them to the conventional stepwise approach that we do currently. So in the red on the left-hand side, we see HbA1c comes down below 6. This is from diagnosis and remains so for 4 years. Well, in terms of the stepwise approach, even here, they were done tidily, we seem to lose control in the green line. On the right-hand side, what we see is cumulative survival, so failure of achieving a target of less than 6.5%, significantly greater in those who went to triple therapy from the start. An interesting thing here is despite getting the HbA1c low, remaining low, there were low risk of hypoglycemia in those who had triple therapy from the start. And STENO2 is one of the best studies about multifactorial risk factor control. As you know, in this study, these patients had type 2 diabetes and microalbuminuria. For randomization, they went for risk factor control in terms of blood pressure, lipid control, HbA1c control, and patients were also put onto aspirin. And we now have 21-year-old data showing that there was reduction in heart failure by about 70%, reduction in stroke by 70%, and the most astonishing is 8 years of life gain. So early tight glycemic control not only improves microvascular, macrovascular complications, but they get 8 years to live longer as well. This is trying to translate this into the real world setting. This is using CPRD. We're trying to emulate what they did in the STENO2 study. These were patients with type 2 diabetes and microvascular disease. And again, in this study, we showed that simultaneously achieving HbA1c target, cholesterol target, and blood pressure target was associated with a 41% reduction in ischemic heart disease, 25% reduction in cerebrovascular disease, 42% reduction in end-stage kidney disease, 55% reduction in cardiovascular mortality, and a 42% reduction in all-cause mortality. So not only is there evidence that tight risk factor control in randomized controlled trial, but we see this in the real-world setting as well. One of the reasons for not achieving tight glycemic control has been termed therapeutic inertia, failure to advance therapy when appropriate to do so. Now, a lot of people think this may only be occurring in 1 or 2 countries, possibly low-income countries. Unfortunately, therapeutic inertia is a global phenomenon. This is a systematic review of over 50 studies when we looked at all the countries that reported therapeutic inertia. So what this study shows is when we are on 1 therapy, 2 therapy, or 3 therapy going on to insulin, we wait anything from 1 to 7 years, despite the HbA1c being high. Now, what does that lead to? So on the left-hand side at the top, what we see is it leads to worse microvascular disease. On the right-hand side at the top, therapeutic inertia is associated with increased mortality. At the bottom, we did the study looking exactly like UKPDS, but showing that therapeutic inertia is associated with cardiovascular risk as well. So not aiming for early targeted risk factor control leads to worse outcomes, microvascular outcomes, macrovascular outcomes, and mortality as well. So what can we do about it? Well, this is the first, I think this is the only systematic review of trying to overcome therapeutic inertia. Here we looked at 36 studies, over 22,000 participants. One take-home message here is, first of all, having physicians do anything. Sorry about this. Having physicians do anything is useless, as you can see here. Physician interventions do not make any difference at all. However, if we have pharmacy-based interventions here, or nurse-based interventions, that leads to reductions in HbA1c. And this is a model of care that many countries are trying to emulate. So in the UK, I don't see many patients with diabetes at all. It's my nurses and pharmacists who look after them. It's much more cost-effective, and there's data to show that. And they're more likely to run to protocols as well. So there is now ample evidence that we can overcome therapeutic inertia. Improving adherence is very important. This is data showing from people with cardiovascular disease, people with type 2 diabetes, without CVD or CKD, and people with CKD. What we see here is adherence rates go down to around 50% just for statins. So really, really poor adherence within 1 year of us commencing these therapies. These are mainly done using large databases. The only way to do good quality adherence studies is by looking at urine metabolites. And this is exactly what we did in this study, looking at 200 patients who bring their urine sample for microammonia testing. We looked at the urine metabolites for, now we can look at about 60 metabolites. And in this study, we showed that adherence rates were low for particularly sulfonylureas, GLP-1 receptor agonists, and statins. All the others are ACE inhibitors, ARB, calcium channel blockers, beta blockers, and diuretics. There was some variable adherence there. People who were non-adherent had worse HbA1c, worse albumin-creatinine ratio, and worse lipid control, significantly higher in those who were adherent compared to those who weren't adherent. So the best way to check adherence is for looking for objective measure in urine metabolites. Why does it matter? Well, again, if you look at this is a systematic review of a number of studies. We looked at 8 observational studies that people who are adherent, they're less likely to be admitted. Hospitalization is reduced by 28%, all-cause mortality reduced by 10%. So adherence does matter. How do we improve adherence? Again, here we looked at a systematic review of all the adherence study. What we see is single-faceted interventions don't help as much. Multifaceted interventions, and we can talk about what interventions they include. Some are very, very simple reminders on telephone calls, seem to have a better effect in improving adherence compared to simple one-faceted interventions. De-intensification is an important issue, and we don't give much emphasis to de-intensification. Many studies, this is from the Accord trial, BADT trial, what we see is tight glycemic control after a number of years may not matter. So after 18 to 20 years, having tight glycemic control may be more harmful than beneficial. So we need to weigh the risks and the benefit balance then, say, do we really need to go for tight control for these patients who've had diabetes for 20 years, because may not make any benefits at all. Age is important. This is really nice data from the emerging risk factor collaboration. If you're age 40, it makes a big difference. Going for tight control, you can potentially have 6 years of life gain. This is looking at people with diabetes compared to those without. You lose on average 6 years of life. However, if you're aged about 75, you lose about 6 months of your life. So you may have maximum of 6 months of life years gained by doing everything that we can do for that patient. So then we need to think about, do we go for a tight control there? Hypoglycemia is very, very important, particularly when we get into the older population. I'll be talking about that later. As you can see, this is the data we looked at for the whole of England. So every hospital admission in England. And you see the hypoglycemia increases from the age of 50. These were mainly type 2 from the age of 50, younger age type 1s at the left-hand corner. Now, there are 2 observations. First of all, there's a steep rise in admission for hypoglycemia after the age of 50. Second observation is, despite having excellent therapies to our armament, we don't seem to have improved admissions for hypoglycemia. As you can see, they haven't changed much at all. So either we're intensifying too much in certain patients, or not de-intensifying, or not using appropriate therapy for the right patient. And this is what we call quaternary preventions, interventions that protect the group of people who are at risk of over-medicalization. So therapeutic inertia has 2 in their definitions: failure to advance therapy, or to de-intensify therapy when appropriate to do so. Structured education, this is another area we don't give as much emphasis to our patients. We're easily writing prescriptions for £100 a month for injectable therapies for some of our patients. Whether they take it or not, we don't know. So therapeutic inertia, again, the evidence base is really, really strong. This is a systematic review of all the self-management education programs. And what we see here is this improvement in HbA1c, improvement in fasting plasma glucose, improvement for diabetes knowledge for that patient, self-management skills are improved, self-efficacy, that patient feels more empowered about managing their diabetes, the weight is improved, and there's treatment satisfaction. Just imagine if you had a tablet that did all this. We would snap that up. However, we don't snap up education programs for our patients. And by this, I don't mean when we see a patient in a clinic and we tell them to do this. This is a structured, psychologically underpinned self-management program that's given separately, and often it takes about 6 hours of education per year. This was the first and the largest randomized controlled trial of type 2 diabetes that we conducted in the UK. What you see here is at 12 months there were benefits in terms of HbA1c reduction of about 0.5%, which wasn't significant, but 0.5% it was. There was improvement in physical activity, there was improvement in proportion of people who stopped smoking, there was improvement in body weight, and there were improvements in depression and illness coherence in terms of what patients felt they could do about it. And many of these outcomes were maintained at 36 months. The cost effectiveness of this shows Desmond program, it cost only £82 per year. As I said, we're willing to give therapies that are £100 a month, but we do not seem to put emphasis on self-management education program, and this was shown to be highly cost effective. Finally, just looking at cost effectiveness approach, and you might think I'm talking about this in a low middle income country, we talk about this in the UK as well. We do have finite resources, so we need to make sure that we are using them appropriately. This is a really nice study by Neda Letfong in the US, showing that individualized HbA1c target, rather than going for a same target for everyone, is very cost effective, reduces costs and increases quality of life compared to uniform intensive control. This is from the STENO-2 study, multifactorial risk factor control, and again what we see here is in the STENO-2 over 21 years there was no difference in cost between the intensive arm and the control arm that I showed you. The mean cost per patient was significantly lower in the intensive arm, but most of the benefits were because of the inpatient admissions that were avoided in the intensive arm compared to the control arm. So in summary, what we should be doing is when the patients are early on, we diagnose them, go for tight risk factor control, diet, exercise, metformin, and all the appropriate therapies as the guidelines suggest to us. As the disease progresses, we need to think about complications, avoiding complications. If they have complications, manage these appropriately. And then the older patients, we need to think, do we really need to go for tight control? Because this is where we may think quality of life is more important than anything else. So, individuals with type 2 diabetes, start lifestyle, early multifactorial control, avoid therapeutic inertia. As we say, we tend to loosen the targets, but we should be going for a target for risk factors from the get-go as a diagnosis. Use the therapies that have a really good evidence base in terms of SGLT2 inhibitors, GLP-1 receptor agonists for the appropriate patients with cardiovascular disease or kidney disease, and continue avoiding the loosening of the targets. Thank you very much for listening.
Thank you, Dr. Kunti.